64-year-old male underwent laparoscopic cholecystectomy. Perioperatively, severe cholecystitis with loss of landmarks was encountered by the surgery. An attempt was made to complete the cholecystectomy, but it failed. A JP drain left in the gallbladder fossa. On postoperative day 1, gross biliary drainage was encountered in the JP drain. Ercp revealed only distal CBD opacification and large biloma with minimal proximal biliary opacification and inability to cannulate the proximal CBD. CBD was probably severed at the cholecystectomy attempt. Interventional radiology tried PTC approach and again failed to enter the distal CBD, and large biloma was confirmed. It was concluded that there was a near complete transection of common bile duct at the cystic duct junction level. Ercp using sphinctertome. Guide wire was inserted through the sphinctertome and kept going into the biloma. Wire was also dropped down by the interventional radiologist from top. Repeated attempts at entering the proximal biliary tree initially failed, and finally, with manipulation of the sphinctertome, the guide wire entered the proximal common bile duct through the biloma or resected common bile duct area. Here on the screen you can see that the guide wire finally entered the proximal common bile duct, and there is an acute angulation probably making it difficult to place a stent. The wire was also dropped through the PTC catheter by interventional radiologist just to confirm that both guide wires are in the common area. At that time, sphinctertome was replaced by stone extraction balloon, size 15, and the balloon could follow the guide wire better than the sphinctertome did due to the angulation of the sphinctertome. The balloon was now in the proximal common bile duct, as you can see on the screen. Balloon was inflated and cholangiogram was performed, which confirmed that the tip of the balloon is in the proximal common bile duct and biliary radicals were seen. Guide wire was advanced further deeper into the biliary system in order to attempt a fully covered metal stent to cover the defect. The metal stent is moving towards the angled area. As you can see, there is an acute angle which the stent cannot negotiate. So radiologist is going to introduce a snare through the PTC catheter to grab the guide wire and take it out through the cutaneous end of the PTC to complete the rendezvous. On the screen you can see a sphinctertome dropped by the interventional radiologist through the PTC catheter is trying to grab my guide wire. Several attempts were done since it is technically difficult in a 2D environment performing a 3D maneuver. So it took a little bit longer to grab the wire. As you can see on the screen, both of us, interventional radiologist and I, are trying to find the right moment to catch the guide wire which was sent over. And you can also see the fully covered metal stent waiting to be introduced into the proximal common bile duct once this rendezvous is feasible. Finally, the glide wire was caught in the snare. The only issue was that the stiffer part of the guide wire would not go through this small PTC catheter, and hence the guide wire was pulled down a little bit so that it catches the floppy portion of the guide wire. Which is being performed right now on the screen. And the snare is closed on the floppy portion of the guide wire and now pulled out, as you can see, through the PTC catheter out to the skin. Once the guide wire was secured between the radiologist and I and was kept taut, the stent could negotiate the angle and was introduced further deeper into the biliary system proximally. Followed by the deployment of this stent, as you can see on the screen. The stent is being deployed. It was fully covered metal stent, size 80 millimeter by 18 millimeter. As you can see, the stent is open now with a little bit of manipulations. The stent is now straight, and the middle part of the stent is probably going through the biloma and the transected portion of the common bile duct. Once the stent was fully open, I did a cholangiogram using the balloon It was an obstructive cholangiogram to confirm the integrity of the stent, and a nice cholangiogram was performed, which can be seen on the screen at this moment. this completed this novel procedure performed between me and the interventional radiologist and was successfully accomplished. Here is the stent endoscopically, and here's the day 2 where the stent is intact. Thanks for watching.